And not a lot is known about ovarian cancer. And talks with women, and hopefully some men are here today, these are vital in our efforts to try to raise awareness of this disease, because around 40,000 women are living with ovarian cancer in the UK at the moment. And our charity, which I'll tell you something about as we go along, spends millions of pounds looking at research into treatment, trying to find a guaranteed screening tool. But the very first rung on the ladder to improving outcomes from this disease is increasing awareness. We raise awareness, we get better outcomes, and women live longer. And two key problems with raising awareness, or the focus on raising awareness, is firstly with the general public, women, and as I say, the men in our lives, because we've all got to be involved in this. Unfortunately, around 90% of women are still unable to name all 4 symptoms of this disease. And that's why too many women present too late with symptoms. But also amongst health professionals, trying to improve the knowledge of health professionals, doctors, in identifying the symptoms of this disease, because too often diagnosis is missed at an early stage when a disease can be more effectively treated. And to show you a very graphic and stark indication of the damage that late diagnosis causes, something like 58% of women are diagnosed at an advanced stage. That's stage 3, 4. Of those 58%, 90% of women die within 5 years. So put it another way, in over half the cases diagnosed, 90 out of every 100 women will die within 5 years, and sadly, often considerably within that period. So that shows you how damaging late diagnosis is and how much we've got to work on getting earlier diagnosis. And over 5-year survival rates from this disease compare pretty much the same as what over 5-year survival rates from breast cancer were in the 1970s. So this is not acceptable in 2022, and this is something we've all got to do something about. So I'll give you some information today. Firstly, who we are and what we do. What ovarian cancer is. Some facts and stats about the disease, and he puts it in comparison with other diseases experienced by women in the UK. Key section today, what the symptoms of ovarian cancer are. Some information about how it's diagnosed and treated. Another very important section, what affects a woman's risk of getting ovarian cancer. Then, as Ronan said at the end, we'll have some questions and answers. So who are we? We are, as it says there, the UK's ovarian cancer research charity. We want to empower women, to give them a voice and create a better future for the thousands affected by this disease. And just as importantly, if not more importantly, reach out to the tens and tens and thousands of women who could be at risk of getting this disease in the future. We do this in 3 ways. Firstly, funding research, and I'll give you some information about that later, but we have a number of laboratories around the country, London, Oxford, Cambridge, Edinburgh, constantly trying to find better treatments and also the holy grail of a guaranteed screening tool. Raising awareness. Sessions like today, trying to spread the message about this disease and its symptoms and reach that message out as far as possible. Also, we have lots of information on our website, which gives more information about this disease. So we always encourage people to look on our website, download this information and share it with family and friends. Campaigning for change, trying to raise the profile of ovarian cancer. And we, amongst others, had one success last summer because the lobbying and the pressure we put on at government level, NHS England in June last year announced that they would be holding an audit on ovarian cancer. Why are survival rates too low? What do we need to do? What are we doing wrong? And that in the coming years will help both to raise the profile of the disease and hopefully to progress treatment. So what is ovarian cancer? It is an uncontrollable growth of abnormal cells within or around one or both ovaries. Ovaries being part of the female reproductive system. I will refer to some of the other gynae cancers as we go along today by way of comparison, but it is very specifically a talk about ovarian cancer. There's three types of this disease. The most prevalent, which accounts for 90% of all cases, is epithelial ovarian cancer. This is where the cancer develops or is made manifest in the epithelium, which is the lining to the ovary. The other two types, germ cell and sex cord stromal, account for about 10% between them. And overall, something like 82% of all UK cases are diagnosed in women over the age of 50. So when we come on later to look at risks and triggers, age is a key risk in that the predominant amount of cases are in women aged 50 plus. But it is important to emphasize that it can strike at any age. It still leaves 1 in 5 women who get the disease who are under 50. And we have a volunteer who works with our organisation. His daughter was very sadly diagnosed at the age of 19, and she died just before her 21st birthday. So must emphasize that it can strike at any age. In terms of how it compares with other cancers experienced by women, the highest profile, the most numerous, which would be no surprise to any of us because it's probably the one we know most about, breast cancer, with about 55,000 women diagnosed each year in the UK. Lung 23,000, bowel 18,500, womb 9,500, skin 8,000, and ovarian 7,500. So ovarian cancer is the 6th most common cancer experienced by women in the UK. But the even more concerning figure is that 4,200 women die from ovarian cancer each year. That's 1 woman every 2 hours. And more women die of ovarian cancer than all the other gynae cancers combined. Now, if you aggregated the number of cases each year from cancer of the womb, vulva, vagina, cervix, there's around about 14,000 diagnoses. So approaching double the amount of diagnosis of ovarian cancer individually, but more women die of ovarian cancer. And that's a very stark figure because it's still a killer disease. And that's what we need to address and do something about. Survival rates are far too low in the UK and lower than many countries in Europe. We only have around 43% of women surviving beyond 5 years. Not acceptable. When we were in the pre-COVID days of a face-to-face session, I always used to have a little just bounce around the questions around the people attending to see if people did know what the symptoms or what they felt they were, because as I said at the start, 90% of women are unable to name all 4 symptoms. Now, that's not possible in this particular type of forum, but I'd just like you to think for a few seconds as to what you think might be the symptoms of this disease for those of you who don't know. So the 4 main symptoms of ovarian cancer are bloating, stomach pain, weeing more, struggling to eat. Now, you might look at those 4 symptoms and an immediate reaction from a number of you might be they are vague and could be a symptom of a number of other things. So what are we then saying? What we're then trying to say is, okay, if these symptoms are severe, persistent, frequent, come on for no apparent reason, and don't go away, this could indicate a problem, could indicate a problem with ovarian cancer. Yes, these symptoms could indicate endometriosis. And some of you may have endometriosis who are here today, but that's a known condition. Those women who have that, or some of you may have what I have, which is irritable bowel syndrome. We can have a couple of those symptoms, but we know that. We know we're living with it. What we're saying is if these 4 symptoms or any of them come on in a severe, persistent and frequent way for no reason you're known of, do something about it. And in this country, that do something about it is make an appointment with the GP. Now, that's been very difficult over the last 2 years because of the focus on COVID. But we have to get into the doctors, get a consultation with the doctors and discuss when these symptoms become apparent, because the earlier they're addressed, the better the chance of outcomes. And this difficulty, as I say, of getting a consultation with the GP, that's something we have to work on. But there are some other potential symptoms, back pain, difficulty with bowel movements, but they're even more generic. It's really these 4 symptoms, trying to drill it down to that as a trigger to act and get into the doctor. Doctors are busy, and it has been difficult to see them, but what we have to do is make the most of the time with the doctor. And one of the things we have on our website is a symptoms diary. You can probably see it there in the right-hand corner, right-hand half of the screen. There's 4 main symptoms are listed down the left-hand side. There's 4 weekly columns across the top and 7 days against each symptom and week. What we're saying is, if you feel these symptoms coming on, tick the boxes. If at the end of a month, there's lots of those boxes ticked, this is something to take into the doctor and say, I have not felt these symptoms before. There's something wrong here. I need an investigation. And too often I hear that women are fobbed off. Oh, it's the menopause. Oh, it's your age. Oh, it's probably a bowel issue. Come back in a couple of months. No, don't accept that. Sometimes you have to be aggressive, pushy, shall we say. And if you're not of that type, bring someone with you who is and won't take no, and say, look, I am concerned that these symptoms could possibly be ovarian cancer. Please, I want the next stage seen to. And I'm going to take you through a hypothetical pathway to diagnosis here, whilst making the point that in the majority of cases, it is not going to be ovarian cancer. But the quicker, if it is diagnosed, the better the outcomes. So there's no guaranteed screening tool for ovarian cancer at the moment. 1 in 4 women believe mistakenly that the cervical smear test detects ovarian cancer. It does not. So please, any of you who might think that, is completely untrue. What your doctor should do, if he or she is concerned that you might have ovarian cancer, is send you for a CA-125 blood test. And this is what you should ask for. CA-125 is a protein found in the blood, and if it is higher than a normal level, it could be a sign of ovarian cancer. The unreliability of it is, it could indicate fibroids, it could indicate endometriosis, it could indicate none of the above. And it is possible for a woman to have a normal or lower than normal reading CA-125 and still have ovarian cancer. I had a little session with some people from Nottingham University last week, and a woman who spoke there was diagnosed at 26, and she had a normal CA-125. But at the moment, until we find that guaranteed screening tool, it's the best we've got to work with. And if it is higher than a normal level, your doctor should then refer you to the next stage. That would be a pelvic or transvaginal ultrasound scan to see if there's any unusual masses there, exploratory surgery if there is, biopsy, and then if it is a diagnosis, that follows that. Now, that all sounds very neat and tidy, doesn't it? Presentation to doctor, CA-125, result, scan, biopsy, diagnosis. But it takes too long. And nearly 50% of women in the UK wait 3 months or more, and sometimes a lot longer, for their diagnosis. We need to reduce the time it takes from a woman presenting to the doctor to getting diagnosed. This means more education of doctors, but also more diagnostic centres. But if you then add to that at the front end, delays in a woman presenting with symptoms, that's where we get the real problem. We've got 2 delays built in. We need to work on the awareness at the front end and speed up the diagnosis at the following end. Let's assume in this hypothetical case, ovarian cancer is diagnosed. It has 4 stages. Stage 1, the cancer is contained entirely within the ovary or the ovaries. Very good outcomes, very positive outcomes, with something like 93% of women surviving beyond 5 years, and often a lot longer than 5 years. Stage 2, cancer may have spread to the fallopian tubes, the womb, bladder, bowel, and pelvic area, but still good outcomes, with around about 68% of women surviving beyond 5 years. When we get into stage 3, where the cancer affects the abdominal cavity, and stage 4, where it's spread far and wide to other organs, that's where we're in the really problematic stage. And that stage 3 and 4 combined comprises the 58% of diagnosis at the moment, where 90% of women will not survive beyond 5 years. So at the moment, around about 1/3 of cases are diagnosed at stage 1 and 2, and 58% at stage 3 and 4. So we need to convert as many of those stage 3 and 4 diagnoses into stage 1 and 2, then we will make good progress on outcomes. How is it treated? Treatment depends on the type of ovarian cancer and the stage it was diagnosed at. We're gradually learning more and more about this disease, the variants within the types I introduced on an earlier slide. It's a complex disease, and we are, as I say, learning more and more about it through the research we're doing. But usually it'll be a combination of surgery and chemotherapy. Over half women diagnosed will have chemotherapy, but a very, very small percentage will have radiotherapy to treat ovarian cancer because of the proximity of other organs. And the complexity of that area, shall we say, and the surgery required is also a stumbling block, because it's a very, very skilled job, obviously, to remove the cancer from this area prior to having treatment. And we just don't have enough skilled surgeons in the UK to carry out this debulking surgery, as they call it, to strip out as much of the cancer as we can before chemotherapy starts. So we need more surgeons. Outcomes are better, as I will keep saying today, when women can be treated at an earlier stage. Early diagnosis is the key to improvement. And the opposite side of that is, because of the prevalence of late diagnosis, there's a 70% chance of ovarian cancer coming back after treatment. Very, very high percentage. What affects a woman's risk of getting this disease? The 2 most important factors: family history and genetics. It is vital to know family history, and I'll come on to that in more detail in the coming slides. As I said earlier, over 80% of women diagnosed are age 50 plus, so that's a key risk trigger. There are some more minor risks. For example, a long menstrual history. If a woman, say between the age of 16 and 50, has an unbroken menstrual history, she has a slightly enhanced risk of getting this disease compared to a woman who has born children and or spent time taking the oral contraceptive pill. It seems to simplistically come down to less ovulations, less risk, basically. Sounds very simple, but that's what it seems to come down to. Endometriosis in women over 50, particularly, slightly enhanced risk. HRT, but again, it's a very slight risk. and that's probably outweighed in most women's minds by the benefits of that. So it's a risk versus benefit situation. Not really linked to lifestyle in the way that, shall we say, smoking is linked to lung, diet is linked to bowel, but still important to lead a healthy lifestyle. So I said earlier in the last slide, family history, genetic mutations. I don't know if any of you here today have heard or know anything much about BRCA1/2 gene mutations. If you don't, you're in a very wide club, because about 75% of women know little or nothing about BRCA. And this is another thing of the awareness, to raise awareness of this mutation, because it is important and it exists. We all have these genes, men and women. What they do, if they're working properly, is they prevent cancer from developing. So as our cells degrade, these genes kick in and make them healthy again. If these genes are defective, this doesn't happen. The cells continue to degrade, multiply until they become tumorous. And it's a very important issue in terms of ovarian cancer, because it accounts for about 15% of all cases each year, and that's 1,000 women. 1 in 400 women carry this gene mutation, but it's very much higher in some communities, Pakistani, Polish, Icelandic, and very high within the Ashkenazi Jewish community, where about 1 in 40 carry this genetic mutation. So it is very important, particularly for members of that community, to look at their own family history. It does increase the risk of cancer in men too, particularly prostate cancer, but the risk is lower than the risk of women carrying this genetic mutation getting ovarian or breast cancer. A parent has a 50% chance of passing it on to their children. The only good news is it cannot skip a generation. So if it does not pass directly from parent to child, it disappears. And eligibility is an issue for 2 reasons. One, so little awareness of it. Women don't look at their family history and so don't know to ask about potential BRCA gene testing. The general rules are that women who have the majority of cases of ovarian or breast cancer are eligible for testing at diagnosis, as are people who can show a strong family history of these cancers. But sometimes the difficulty in converting that into a test is cost. A full BRCA gene mutation costs over £1,300 these days. So there's a reticence to refer women for it. Add that on to the fact that there's a lack of awareness of it, so people don't know to ask. That's where we get into the situation where there isn't enough knowledge of it and enough women and men who are diagnosed with this. If, let's say, a woman goes through a BRCA gene testing and she is deemed to be BRCA positive, there are risk reduction options. Basically, double mastectomy, ovary removal. That cuts the risk of getting this disease, ovarian or breast cancer, for the future. But it's not a diagnosis. It's presenting women with the information that they understand the risk and can make their own decision. And some of you may remember a number of years ago, Angelina Jolie went very public and said she had looked into her family history, saw the prevalence of these cancers, had the testing, was tested BRCA positive, so she decided to have that risk reduction and had both her breasts and both her ovaries removed. So that gave it a blast of publicity. I don't know if any of you have watched a program called The Bold Type on Netflix, but very engaging, very enjoyable program. But one of the younger women in that, she's in her mid-20s, she finds out she's BRCA positive. And it just takes through the decisions, the issues she has to consider. And all these things help to raise awareness of BRCA. And to show you here on the little graph, just what a difference it does make. About 2% of women in the UK are at risk of getting ovarian cancer. This rises from 10 to 20% for women carrying a BRCA2 and 40 to 60% for those carrying a BRCA1. Even more enhanced in the case of breast cancer, where the general percentage of 11% rises from 45 to 60% for women carrying BRCA2 and 60 to 85% for carrying BRCA1. So it's very, very important to find out family history. And we have a whole section on our website which deals with BRCA, much more detailed than I'm giving you here today, what entitlement to testing is, how to talk to your doctor, even download letters to take into your GP, because we all get flustered when we're with our GP. We all come out sometimes not saying the right things. So simple letters and information about the impacts. But the starting point is find out family history. And on our website, you'll see a little, for those of you who are concerned afterwards and want to look into this, we have a little tool, just basically half a dozen questions around family history. And at the end of that, we'll pop out saying, well, yeah, perhaps there's something here you need to look at, or no, it's okay. And just as we looked at symptoms earlier, the starting point is to go and make an appointment with the doctor. Talk to him or her about your family history. Say you've looked at it. And a very, very rough rule of thumb is if on one side of your family, 2 or more women have had breast or ovarian cancer, this could indicate the presence of a gene mutation. Could, again, doesn't mean it does, but it means if you're so inclined, go and talk to the doctor about it and see if you're entitled to BRCA gene mutation testing. In addition to trying to spread the word of awareness, there are really exciting things going on in terms of research at the moment. That's our research and other organisations in the 3 key areas of prevention, early detection and treatment. Prevention, trying to get down to the cellular level and find markers which might predict which women are more susceptible to getting ovarian cancer in the future, so we can attack it from that level before it even develops. Trying to find a guaranteed screening tool. You know, huge progress being made by Professor Ahmed, who you see one of the pictures there at Oxford. You know, we're hopeful in the next 5, maybe 10 years, we will have this screening tool, and that will be a major advance. Treatments are getting better all the time, more personalized treatment. The real sort of game changer, as they say these days, will be genome testing, which most of us, I certainly only ever heard of for the first time in relation to COVID. But this genome testing is able to pinpoint the exact variant, the exact type of ovarian cancer for which the treatment can be targeted at. The drugs are getting better, and not only extending a woman's life, but extending quality of life. So all these things, terrific progress being made, and will continue to be so in the next 5 or 10 years, and will lead to progress. And as we're wrapping up today's little session, the things to remember, the key things to remember out of today: know and be able to identify the 4 main symptoms: bloating, stomach pain, weeing more, struggling to eat. Act quickly. If these symptoms come on for no apparent reason or pre-existing condition and are frequent, persistent, and don't go away, act quickly. Go to see a doctor. Make an appointment with the doctor. Every referral pathway starts in this country with the GP. Go and see the GP. The cervical smear does not detect ovarian cancer. Think about risks. Find out about family history. If you are concerned about it, look at our website. There's lots of information there. As I say, a complete section with BRCA, but there's even bite-sized information, Facebook, Twitter, all these things. And to conclude, really, the key message is
early diagnosis. We improve symptom awareness, we get those messages out to improve symptom awareness, we will get earlier diagnosis and better outcomes. Look at the few percentages we discussed. For women at stage 1, 90% will survive beyond 5 years. Stage 2, 68% will survive beyond 5 years. We get down to stage 3 and 4, which is over half of diagnosis, 90% of women will sadly die within 5 years. Always a concerning and a shocking figure to me is 30% of women will be diagnosed as a result of emergency presentation. So they either go to A&E, they're in so much pain, so much agony, or they're referred to A&E by the doctor. And this is what drives the overall mortality rate from ovarian cancer of 75%. 75 out of every 100 women who get this disease will die within 5 years. And my mother died of ovarian cancer over 30 years ago, but she fell precisely into that. Didn't know anything about ovarian cancer, and nor did the people around her, like me. We didn't know anything about it. So she kept on going through and kept working all the important priorities of looking after job, looking after family, too busy to be sick and too busy to look after herself. And she let it go too far, as did we, because we'd say, "You okay? Everything all right, Mum?" "Oh yeah, just getting old, just my age, nothing more than that." And she was 52, at precisely now what I know to be a risk area zone. And she left it too late. And basically from the time she was diagnosed to the time she died was less than 9 months, during which she had surgery, chemo, which she was too weak to take. And too often, ovarian cancer is referred to as the silent killer. It's not. This is a misnomer. The problem is that too many women and those around her who are in her life don't know enough to be able to recognize the symptoms and act early. They leave it too late before they present. And that's when it has such damaging consequences. And you look at the other side of that. You look at how positive the outcomes could be if we continue with the two-pronged effort. We continue to raise awareness, get the messages out there to improve symptom awareness so that women present earlier, together with all the advances that are being made in treatment, trying to find a screening tool, as I said, more personalized treatment. We drive those two things along in parallel, which will inevitably lead to progress. It's about the two things really, looking after those women in our lives now, our wives, our mums, our grannies, our aunties, but the future generations, our children, our grandchildren, our nieces. All these things we are doing will improve outcomes at all generations, if you like. And we will get to a stage, it'll take a few years yet, but we will get to a stage, if we drive those two things forward, that no woman dies of ovarian cancer. So that's the slides and the presentation, guys. I'm quite happy, as Ronan said, if anyone's got any questions,